Good afternoon, and thank you for joining today's webinar, Moving the Needle Forward, Key Findings and Insights on Phase 1 of the HPV Vaccine Task Force in Ontario. We're very happy to have you with us here today for this important discussion. My name is Ian Culbert, and I am the Executive Director of the Canadian Public Health Association, and I will be your moderator today. On behalf of CPHA, it is my pleasure to welcome you and to host the session. Before we begin, I want to acknowledge that while we will be having many participants from across Turtle Island, the Canadian Public Health Association and Immunize Canada are headquartered on the ancestral and unceded territory of the Algonquin and Anishinaabe people. So with that, I will turn to some housekeeping items. Before you ask, yes, this webinar is being recorded, and yes, you will be able to access it afterwards on immunize.ca and on Immunize Canada's YouTube channel. If you have any questions regarding technical difficulties, please send an email to immunize@cpha.ca, and we will reply to you as soon as we can. If multiple people are experiencing the same problems, we'll address it live via a broadcast message in the chat, or I'll just come back and tell you what the problem is. As for the questions and answer session, you are welcome to submit or upvote questions for the speakers using the Q&A tab at the bottom of your screen at any point during this webinar, and the questions will be answered at the end of the presentation. Now, due to time limitations, we may not be able to answer all of the questions, but we'll try to get to as many of them as is possible. Finally, we would really like to hear your feedback, so please fill out our 5-minute evaluation survey upon exiting the Zoom platform. We will also be sending it out via email after today's webinar. So, today's webinar will discuss the following topics. 1, key findings from Phase 1 of the HPV Vaccine Task Force in Ontario. 2, next steps to increase HPV vaccination coverage in Ontario's school-based immunization programs. And finally, 3, critical insights on the importance of adult HPV vaccination. With that, I am delighted to introduce to you our 3 speakers, Antonella Pucci, Dr. Vivian Brown, and Dr. Nancy Durant. Antonella Pucci is the manager of immunization initiatives at the Canadian Public Health Association and is responsible for managing Immunize Canada, a national coalition promoting the understanding and use of vaccines approved for use in Canada with reference to the recommendations of NACI. Antonella has been at CPHA since September 2019 when she accepted a position as a project officer with the CanVax project, an online database of curated resources to support public health professionals in improving vaccine acceptance and uptake in Canada. She now leads an immunization team of 3 people and focuses on the development, implementation, and evaluation of immunization activities, such as knowledge translation resources for health professionals and the public, campaigns, and stakeholder relations. Antonella has a Master of Arts in Communications from Carleton University with a specialization in public health and vaccine promotion. Next, we will have Dr. Vivian Brown, who, quite honestly, Vivian and Nancy, they don't need introductions. You all know them, but I will anyway. Dr. Vivian Brown is a family physician and author in Toronto. Educated at McGill University, she is currently appointed to the Department of Family and Community Medicine at the University of Toronto, holding the rank of assistant professor. An award-winning winner for teaching on many levels. Her major interests are in the areas of health promotion and prevention for women and continuing medical education, adult immunization, and vaccine preventable illness. The College of Family Physicians of Ontario named Dr. Brown Physician of the Year for the region of Toronto in November 2012. She is the past president of the Federation of Medical Women of Canada and is immediate past vice president for North America for the Medical Women's International Association. Recently, she was named one of Canada's most influential women by the organization Women of Influence for her work on advocacy on HPV vaccine for Canadians. In March 2017, she was honored to present HPV initiatives in Canada at the United Nations meetings for the Commission on the Status of Women. In 2018, she was honored with the Media Award from the North American Menopause Society for her work in women's health. She also received the May Cohen Award from the Federation of Medical Women of Canada for her work in women's health. In September 2024, she received the Reproductive Health Award from the Federation and was also awarded the King Charles III Coronation Medal for her work in the community. The College of Family Physicians of Ontario just awarded Dr. Brown with a Certificate of Recognition, a patient-nominated award for her outstanding contributions to patient care. Her most recent book, The New Woman's Guide to Healthy Aging, was recently published to rave reviews. And last but not least, Dr. Nancy Durand is an associate professor in the Department of Obstetrics and Gynecology at the University of Toronto. She earned her medical degree from McGill University in Montreal, where she also completed her residency in obstetrics and gynecology. Dr. Durand is on staff at Sunnybrook Health Sciences Centre in Toronto, specializing in colposcopy with the Department of Obstetrics and Gynecology. Her primary area of interest is the prevention of HPV-related diseases and cancers through HPV vaccination. An international key opinion leader and speaker, she advocates for adult HPV vaccination in both females and males to reduce the burden of HPV-related diseases. So to start off with, I would like to welcome our first speaker, Antonella Pucci, to present. Antonella, the floor is yours.
Thanks, Ian. Hello, everyone. My name is Antonella Pucci, and I'm the Manager of Immunization Initiatives at CPHA, working in Ottawa, Ontario, on the unceded territory of the Algonquin Anishinaabe. So in 2024, we convened an Ontario-specific HPV Vaccine Task Force in response to the alarmingly low HPV immunization rates in the province. In this presentation, I'll highlight some preliminary results from the first phase of the task force, and we hope these findings will pave the way for phase 2, which will focus on advocacy efforts to increase HPV vaccine rates across Ontario. As for disclosure, this project was made possible by the financial support of Merck Canada Inc. through an unrestricted sponsorship. The opinions expressed in this presentation are those of CPHA and task force members. So now on to the HPV Vaccine Task Force in Ontario. So in the task force, we engaged health professionals in a series of action-oriented discussions aimed at increasing acceptance of the HPV vaccine. The specific target audience were parents and guardians of children aged 17 and under in Ontario. The work conducted by this task force was at the time intended to support the 2025 targets set by the Canadian Partnership Against Cancer and the National Advisory Committee on Immunization in achieving 90% HPV vaccination coverage in adolescents by the age of 17. In Canada, HPV vaccination rates vary across and within jurisdictions, with rates in 2017 ranging from 57 to 91%. In Ontario, the vaccination rate has often been on the lower end of this spectrum. For example, pre-pandemic HPV vaccination rates for children aged 12 were maintained at around 60% in 2018 to 2019. However, the COVID-19 pandemic severely impacted public health's ability to deliver vaccination programs in school settings, causing Ontario's HPV immunization rates to drop as low as 0.8% in some regions in 2021. And this was for HPV. So, inspired by the success of the Federation of Medical Women of Canada's National HPV Task Force, we aim to address these specific concerns in Ontario. So, through direct outreach and a public application form, we recruited public health units, primary care providers, allied health professionals, and experts from governmental and non-governmental organizations, as well as academic institutions, to become members of the task force. In the end, we recruited approximately 33 general members and 6 advisory board members. General members were invited to attend our workshops and share their insights, drawing from their knowledge and experience in school health and immunization. Advisory board members consisted of experts from various regions in Ontario who provided guidance and expertise on developing best practices. In this slide, you'll see a list of our advisory board members, including Dr. Vivian Brown, who will be presenting after me. So we hosted a total of 4 workshops in 2024 to facilitate learning and knowledge sharing. The 4 workshops were structured as follows. Workshop 1, we conducted a SWOT analysis to explore the strengths, weaknesses, opportunities, and potential threats. Workshop 2, we carried out a barriers analysis to identify the social determinants and challenges experienced by adolescents, their parents and guardians, and by healthcare providers administering the vaccine. Workshop 3, we examined existing implementation strategies to identify opportunities for HPV vaccination programs. And finally, workshop 4, we defined the metrics and indicators necessary to measure HPV vaccine uptake. So, according to the SWOT analysis, catch-up programs were identified as one of the biggest strengths. Another strength was the ability of the HPV vaccine in schools, making it easier to vaccinate the target audience. Additionally, extending eligibility to high school students was also seen as a significant advantage. Additionally, the promotion of cancer prevention messaging is continuing to emerge and has been a key strength as well to help encourage parents to consent to having their children vaccinated. As for weaknesses, the number of doses required was seen as a challenge, as follow-up in completing the series has been difficult, and this weakness was presented prior to NACI's updated 1-dose recommendations. Other weaknesses include the lack of involvement of other health professionals, such as dentists, in vaccination efforts. Also, the absence of a centralized records database and the lack of knowledge about the importance of HPV vaccine among adolescents and their parents was also noted. In terms of opportunities, there is significant potential to increase education, communication, and promotion efforts around the HPV vaccine and cancer prevention, and to eventually create a vaccine registry in Ontario. Recently, Public Health Ontario released a position statement urging for this development. Finally, threats identified by task force members included the lack of universal vaccine registry in Canada and the ongoing spread of mis- and disinformation. As for barriers, contributing to these weaknesses and threats are barriers for parents, barriers for guardians, and barriers for adolescents, which include a lack of communication, like reminders and plain language and consent forms, a lack of access, like opportunities for missed school days, or a lack of family doctor. Religious beliefs and needle phobia were also noted as barriers, and apathy and stigma, such as the vaccine not seen as important or being called just a sex vaccine, was also considered a barrier. On the other hand, barriers for healthcare professionals include a lack of feasibility and time constraints, as they often only have 10 to 15 minutes per patient, and routine immunizations are not always prioritized. A lack of communication between care teams. So if one profession is not fully involved in the vaccination process, it can create delays or obstacles. Barriers such as communication challenges of patients were also noted, particularly around effectively discussing the HPV vaccine, addressing misinformation, and countering parents' predetermined opinions. Policy barriers such as pharmacists not being permitted to administer the vaccine to adolescents and a lack of vaccine registry was also noted, making it difficult for allied health professionals to know which patients still need to be vaccinated. And lastly, vaccine availability was also noted in some regions. Additionally, an important mention that was noted in the task force is that healthcare professionals are faced with fewer resources, but the same expectation to accomplish more, which really speaks a lot to our current state. I went a little bit ahead. So, however, on a positive note, task force members did share a number of success stories that can help in implementing strategies, such as finding multiple opportunities for increasing vaccine coverage through school vaccination programs. In Ontario, school vaccination for HPV is offered to grade 7s, but what if a student missed getting vaccinated that year? Well, Durham Public Health allows for grade 8 students to participate in the grade 7 vaccination programs, and Wellington Dufferin Guelph goes back into high schools to offer the HPV vaccine to students and even offer summer catch-up programs. This has been noted as costly, but it also has been seen as effective. Another one was a combination of electronic and paper consent forms for those who are living in limited internet access. Conducting follow-ups of individuals who have not returned consent forms or who have missed the HPV vaccine is also essential. For example, Kingston Public Health used this opportunity to address the HPV vaccine, which is not covered on the Immunization of School Pupils Act, but they decided to use this opportunity when discussing those who have not been vaccinated under that act to discuss the HPV vaccine as well. Other strategies are communicating via multiple channels. So for example, public health nurses in Durham Public Health give presentations in schools to educate grade 7 students about vaccines and the importance of vaccination. Engaging with community partners was also noted, as it can be especially helpful in targeting vaccine hesitant populations. Wellington Dufferin Guelph was successful in these efforts in the region, being able to foster trust with certain community members and addressing misconceptions. Practicing people first strategies is also essential through individual conversations and personal recommendations. For example, Durham Public Health does this through motivational interviewing techniques. And finally, starting the conversation earlier can also help. So Windsor Essex taught HPV immunization to grade 6 students and then sent the consent forms to parents. They also reached out to the parents over the summer months in hopes of increasing the number of consents. And then just finally, a small recap on metrics. Panorama is the primary system used by public health units to collect vaccine uptake data. Demographic factors such as age and gender are the main variables captured. The most valuable data collected pertains to consents obtained and immunizations administered. And while the database records those who have not been immunized, there is limited action that's taken with this data. So based on the first phase of this task force, preliminary recommendations consist of the following: enhancing communication and education to tackle misinformation, bridge communication gaps, and use targeted messaging to frame the vaccine as a critical tool for cancer prevention. And this is directed much towards parents and adolescents. There's also the need for advocacy for institutional and policy changes, which is more of a long-term goal, such as opening those opportunities for other healthcare professionals to deliver and recommend the HPV vaccine, standardizing consent forms, and having a universal vaccine registry. Other more short-term goals would maybe be discussing using a combination of different strategies to increase vaccine rates, which is essential to ensure broad access and increased uptake. Also, building trusting relationships with communities is fundamental in overcoming the barriers. So maybe working alongside community champions or maybe a healthcare provider within a community who already has established relationships within the communities can maybe help with engagement. And finally, an important thing that was also noted among the different public health units was the collaboration between public health units in Ontario is essential to break down those silos and share best practices on how to improve vaccine acceptance and uptake. As for lessons learned for us who are doing a task force, there's a couple to mention. So the first one is a focused task force membership. So in phase 2, we will refine our membership criteria, prioritizing professionals from Ontario who work with adolescents under the age of 17. While we continue to welcome diverse expertise, this focused approach will better align with our target population. Another lesson learned is strengthening stakeholder collaboration. So enhancing coordination among Ontario stakeholders, such as teachers, school boards, and health units, is essential to avoid duplication and maximize resource efficiency. Um, Third is expert consultants versus advisory board members. So while the advisory board provided very valuable input, time constraints, limited engagement, conducting key informant interviews before the task force meetings and preparing structured discussions, outlining would improve efficiency. Given that we inherited this project from the Ontario Public Health Association, which no longer has staff to do due to funding cuts, we had to kind of build upon those existing work rather than kind of starting from scratch. Another lesson learned is focusing on clear goals and structured deliverables. So phase one focused on a broad research collection process. In phase two, we will set more specific goals, clearly distinguishing between those overarching objectives and having more concrete deliverables. Number 5, in terms of running the task force, breakout rooms in Zoom proved to be more efficient than having a larger group discussion because it fostered better engagement and diverse insights. And their use should be expanded into future sessions, especially if there's a very big group. So workshops were valuable, but may have been too lengthy. So streamlining content and focusing on core activities and providing more advanced notice would improve participation in our workshop efficiency and scheduling. Tools like Doodle Poll could be used to coordinate these schedules. Second last is the importance of a medical writer. So hiring a medical writer to document meetings and develop reports would alleviate the burden on the internal team and enhance documentation quality. And then finally, participant information requests. So attendees requested a list of task force members, including bios and contact details to facilitate follow-up communication. Providing this information in a structured format would support further collaboration. So those are some of our lessons learned from phase one. So as for our next steps, we plan to publish a comprehensive report, which I feel like I've been saying is coming soon for like the last year. And I promise it is going to be coming by the end of 2025. But this delay is yet another example of the importance of engaging a medical writer to support the development of a published report, especially when you're a small team of 3 in a nonprofit. So that is definitely an importance. However, in addition to the report, we are also working on applying for phase 2 funding. As a major finding across all 4 workshops was the need for stronger collaboration among public health units to share best practices and translate opportunities into action. We plan to bring together a selected group of Ontario public health units to participate in joint meetings to exchange ideas and establish shared goals for 2026. And then we'll also have follow-up consultations that will be held throughout the year to assess progress, identify challenges, and refine strategies. So stay tuned for those updates. And I just want to thank Merck Canada Inc. and our task force members for supporting this work. And I invite you to visit immunize.ca to learn more about our progress. But I think we'll end it here.
Thank you very much, Antonella. That's a lot of information. And as we mentioned before, if you have any questions, don't hesitate to put them in the Q&A module at the bottom of your screen, and we will address those at the end. So now I would like to welcome the next speaker, Dr. Vivian Brown, to present. The floor is yours.
Thank you so much, Ian, and thank you, Antonella. So let's go into the workshop 3 discussion review, and that's what I'm going to present. And Antonella touched on a number of these themes already. Next slide, please. So just to remind you that this is where we were prior to 2019. The top line here is meningitis. The dotted line here is hepatitis B, and the lower blue line is HPV. So even before we hit COVID, HPV was relatively low compared to meningitis and hepatitis in terms of uptake. But generally, it was about 60%. Next slide. What we saw, however, with COVID is that we had schools closed. There was no school to be had, and public health was appropriately transitioned and pivoted to deal with COVID, and we're not dealing with routine immunizations. Next slide. When you look at the map, what we can see is Ontario is in the darkest. Ontario had the most days missed of school compared to any other province in Canada, and actually compared to any other place in North America. So we had no school, and with no school, we had no immunization program in the school. Next slide. So what did we see? We saw a massive drop off. And Antonella told you already that the number dropped to 0.08%, less than 1% of the kids were immunized in that 2020-2021 year. And that's horrendous when we look at the fact that our guideline is saying 90% uptake for people under the age of 17 in order to eliminate cervical cancer. So we're way far away from that 90%, and that's incredibly disappointing. What then happened, if we look at the next slide, is the Federation of Medical Women got together. I won't go into details about the Federation except to say we've been around for 100 years, and we looked at this as a crisis in the school system. And we came together with an HPV task force in 2022, 2023, and 2024. Next slide. What we did is we created a number of white papers, essentially drawing attention to this issue, publicizing the issue, going to the government around the issue, and looking at this crisis in Ontario. Next slide. And what we were able to achieve, and this is important because we talk about advocacy, but this was very specific advocacy with a specific ask and a specific response from the Minister of Health. We gave the numbers, we identified the fact that HPV was sadly lacking in terms of uptake, and the kids that were in grade 7 were now in grade 8, 9, or 10 and had missed that vaccine. And what we were able to achieve is we were able to achieve the health minister changing the eligibility criteria so that you could get HPV immunization in the school program up to grade 12 instead of just in grade 7 in order to complete the series. And I think that that was a huge win in terms of advocacy. And I wanted to share that with you as one of the positive things that we were able to do, drawing attention to this crisis. Next slide. So when Immunize Canada called together this a task force, we looked at different opportunities. We looked at the issues around consent forms. We looked at the catch-up programs, and we looked at involving more professions. And all those things are very important in order to have better collaboration. You know, the Federation of Medical Women has used the term no wrong door. There's no wrong door to be immunized. We don't care if you get it at school, if you get it from your family doctor, if you get it in the pharmacy. The problem in Ontario is that we don't have a registry. And Antonella has already mentioned that. So what we did see is we saw a number of themes happening in different public health units that were looking to solve some of these issues. For example, the summer catch-up program in Wellington, Dufferin, Guelph was fantastic, and they were able to offer vaccine for those that had missed it, offer those clinics. And even though HPV is not on the school suspension list, when someone was about to be suspended for lack of being vaccinated, there was discussion about HPV as well. Next slide. There were a number of attitude themes that we talked about in the task force, and these attitude themes included follow-up work, what to do when someone has not come back with the consent, for example. How do you get a consent? And again, in one of the public health units, this one was Kingston, Frontenac, and Lennox and Addington, they used meningitis as the opening to talk about HPV. So when they were following up with anyone who had not returned the consent form on meningitis, they tried to gain consent for both vaccines at the same time, essentially putting together the argument of prevention being what this was all about, preventing cancer, preventing a terrible infectious disease, immunizing and protecting your kid. We also talked about the idea of connecting with community partners, and this extends beyond just public health and finding ways to reach people in different communities, building relationships around trust to turn around those misconceptions and hesitancies. And whether that was with a trusted healthcare professional in the area, whether it was public health nurses going into the schools, it really was looking at teaching. And one of the things that's happened in the last couple of years is the OPHEA now has a vaccination talks toolkit which is available to any teacher in Ontario, looking at the Ontario curriculum, either grades 1 to 8, grades 9 to 12, and it is available to teach issues around vaccination, around health literacy, and around healthy living. So this is a really great idea because what it's doing is it's helping to start the conversation in the school. It's helping to have the teacher be doing some of the education, and there's your community partner, and it legitimizes vaccination as part of healthy living. So that's been a project that's been supported, and it's a free online resource. And so that's the kind of thing we're looking at publicizing so that people know where to go and we're able to get more people in this conversation, because I would argue that it's all about collaboration, and that collaboration needs to be with all the educators, including pharmacists, including teachers, including dentists, etc., in order to really amplify the message. Next slide, please. There are a lot of constraints. There's a lot of barriers. Antonella already spoke about that. And I think the consent form is one of those areas that is an ongoing issue. Well, Can Immunize has done some work on a consent form that is digital. They've already rolled it out in Nova Scotia, and it's been highly successful. So Can Immunize is in talks with the ministry about this as a solution, because what happens with those consent forms, and I remember this as a parent myself, kids come home with paperwork from school. You don't even see it till 10 o'clock at night. It may be left in their briefcase or in their knapsack. You know, sometimes it's illegible by the time you see it. Sometimes you think it's not that important. And so those consent forms are a real barrier to why kids aren't getting immunized. And when we look at the public health units calling back and following up on students who haven't submitted a consent form, that's extremely time consuming and extremely labor intensive and expensive for the public health units. So we want to think about ways around this, and certainly the Can Immunize project, which already has real world evidence in Nova Scotia, is one of those things that I think we should be thinking about in Ontario. We also know that there's policy and funding gaps because people are asked to do more with less money, and that's an ongoing issue in the healthcare system. And so it certainly is true in the public health units. They not only had COVID to deal with, but now they're getting criticized, or at least it's brought to the attention that the school vaccination programs were in dire straits. School vaccination has improved. It's about a 50% uptake now, but 50% is far away from 90%. And that 90% is what the Canadian Partnership Against Cancer has said we need to get to actually eliminate cervical cancer. Next slide. So I've already talked about less resources with the same expectation to do more. And we certainly need to advocate for more support for public health. And just the way Antonella talked about a medical writer in order to put all this information together, we know that public health units are working hard. Some of them have been more successful. Certainly the health unit in Kingston, Frontenac, Lennox, and Addington has been successful, and Wellington Dufferin has been successful. But there's 34, I believe, health units in Ontario. I may be off by one or two. And in different areas, there's different amount of resources, different issues, and not all the health units have been able to be successful. Next slide, please. So when we look at the considerations for the future, it's around building trust. And I think bringing in the school system, bringing in the pharmacist is a way to do this, involving other professions, looking at the data issues. If we can get that registry up and running and have an idea of who has been immunized, then we can broaden the options for immunization, and everybody can input the information into the registry, so that if I, as a family doctor, have a kid in my practice, I can find out very quickly if they've been immunized or not. Because when I see them now and they're already in university, they don't even remember if they got immunized in grade 7 or grade 8. Next slide. I think the registry is something that we've already mentioned, so I won't dwell on this. Next slide, please. And so we know that one issue is to have a provincial registry, and another issue is to have a national registry. And these are two separate issues. And unfortunately, Ontario has many EMR systems. Many family doctors are on different EMRs. So individual data will have to be captured to be available to be put into a registry, because a registry is only going to be as good as the data that's put in. Next slide, please. And so, in general, our task force back in 2022 said we need a provincial registry that's available to all health providers, including parents and individuals. And yes, there's privacy concerns, but people need to know what they've had in order to understand what they still need. Next slide, please. And so the barriers in terms of not having the data infrastructure exist, and we need that central infrastructure, which is going to require multiple logins. We've already done it with COVID. We've seen that we're able to do it. We haven't done it for HPV and the other adolescent vaccines. And so I think there's many healthcare groups that can be immunizers, but we need to make the data that's quite fragmented collated together so that we have full and complete information. And I think my final slide comes up next. And this is the fact that each province and territory has their own registry. And of course, it would be so much better if there was a national registry as people move from one province to another. And what we know happens for hepatitis, for example, in Ontario, it's grade 7, it's newborns in BC. When parents move from one province to another, they don't know what they've missed in their own province, and they don't know what's coming up in the province they're going to. So finally, in September of this year, our top doctor in Ontario did announce that we need to modernize the vaccine registry, calling for a national schedule. And I think this is because we've been making noise. And we've been making noise through Can Immunize. We've been making noise through Immunize Canada. We've been making noise through Public Health Canada. And certainly we've been making noise as a nonprofit organization, the Federation of Medical Women of Canada. So I'll stop here, but I think we need to learn where there's been success, use that information, and try and put that forward so that other areas of the province, other public health units can follow suit and not reinvent the wheel, but do what someone else has done and what someone else has done successfully. Thanks so much.
Thank you so much, Dr. Brown. Lots of material there for our consideration and questions. Remember, you can drop a question into the Q&A module at any time. When I'll just mention briefly, we talk about provincial registries interoperable with each other to make a de facto national registry. And it is one of those things that, quite honestly, the United States is about 20 years ahead of us. I hate to say it with everything else that's going on down south right now, but they have these registries. They work, and it's really, and they have a state system. It's not that different than our provinces and territories. It's about making an investment. Anyway, I can go on about registries for an hour. I will now turn it over to Nancy Durant. Nancy, the floor is yours.
Thank you, Ian. I think that's an excellent point also about registries that we all firmly believe in. So I'm going to switch our gears a little bit away from our adolescent school-based program and talk about the task force in Ontario and the importance of also additionally adult HPV immunization. And these are my disclosures. So what really is our goal? Our goal here is to increase HPV vaccine coverage rates here in Ontario, where we happen to live, but also across our country in Canada, as we have many participants joining us today from outside the province of Ontario. So why should we even consider adult vaccination when we know that the best practice is vaccination before the onset of sexual activity? But the reality, unfortunately, is we have low coverage rates in many regions in Canada. And we also have somewhat of a lack of equity because many of the children who came through that school-based program did not have any access to HPV vaccination based on their age or based on their gender. So I want you to think about adult HPV vaccination in two different ways. One is the way of benefiting the population as a whole, where we're going to fill in those gaps in lower vaccine coverage rates in our school-based program to help accelerate the path to elimination of HPV diseases and cancers. Think of it like a multi-age cohort rationale, where we have adolescents vaccinated as well as younger and older adults. And then the second way we're going to think about this is the benefit to the individual who's sitting in front of us, not just the population as a whole. So we're going to look at, is there risk to the adult who's sitting in front of you? Is there efficacy to vaccination, especially for those people who may have already been exposed to HPV? Because really it is our jobs as healthcare professionals to provide accurate and up-to-date information so that that person can make the best informed decision for themselves. So there's three main benefits that we think of with adult HPV vaccination. Number one is the risk for new exposure. Number two, does vaccination work if we're older? And number three, does vaccination help in those people who've already been exposed? So first, let's focus on risk as we get older. Well, on the left, you can see the prevalence of HPV in women, and these are adult women. You can see it declines with age, but it doesn't decline to zero. So prevalence of HPV, even if you're age 50, is about 35%. And then on the right, prevalence of HPV in men is very interesting. It's higher than it is in women, about 65%, and it remains high regardless of how old you are. So this means that sexually active females and males do remain vulnerable to new HPV-related diseases and cancers through new HPV infections throughout their lifetime. So let's then think about efficacy of vaccination in adults. We know that it's very good in adolescents, but when we look at adult women, we see more than 90% reduction of HPV infection, external genital warts, and cervical precancers. In men, we see almost 90% reduction of external genital warts, and in clinical trials, we've seen very high reduction of high-grade anal precancers. And these effects do last. When clinical trials were followed, those participants, not just for 3 to 4 years, but now up to 14 years, they show no breakthrough cases of disease caused by those vaccine types. So this tells us that these vaccines have long-lasting effect, that they have durability, and that booster dosing has not been shown to be necessary. Now let's move to people who've already been exposed to HPV. So in fact, those who are already infected with HPV do still benefit from vaccination. There's no benefit to the infection that might be existing right now, but it can prevent new infections by other types that the vaccine covers. Remember, the vaccine that we use is covering 9 types of HPV, not just one type. And it also can prevent subsequent disease from future reinfection with the same type that you already have. So we should not be excluding those who have a past or current history of HPV infection or disease from our vaccine discussions. What are some of the reasons that people develop disease after they've previously had an HPV disease episode? Well, you could get infected with the same type through your partner once again, or what we call autoinoculation, yourself to a different site in you. You could have a new infection with a new type. You could have had unresected disease if you went through treatment. You could have persistent active infection where it doesn't clear from you. And you could have reactivation of latent infection that you had many years ago. So when could vaccination help us? Well, it can help to prevent reinfection with the same type from our partner or new infections with new types. It's not going to help with any unresected disease from a treatment that we might have had. It's not going to help with any persistent active infection. It's still a research question where it may help us with reactivation of infections that we had many years ago. I want to touch on some counseling strategies for HPV vaccination because I think, especially with adults, we often find that to be a challenge and we sort of not quite sure what to say and how to say it. Well, we need to think in our practices because we have people on the line here with many different types of practices. So in our own practices, when are some of the times we could bring up these discussions? So for me, here's a few that I think of in my own practice. Anybody who's coming for screening for cervical cancer, that's pretty obvious, or contraception visits, anybody that we're testing for sexually transmitted infection or if we're treating them or external genital warts. But thinking a little bit even further, anybody who's coming in for counseling and they mention that they've had a change in their relationship status, people coming for mental health visits, often that is due to a breakdown in their relationship, or even travel health visits. Because while we think of travel vaccines, HPV really should be one. When we go on vacations, it is well known that many people on their vacation are going to have a new sexual contact. So this could be in discussions where we have travel health visits. We really want to think about how we can normalize this discussion and not think it's difficult and have it be part of a habit that we develop. So, for example, on new visits and on repetitive visits, we talk about, are you on any new medications? Do you have any new allergies? What about alcohol, smoking, and recreational drug use? Well, it wouldn't be that much harder to simply add in vaccination questions, including HPV vaccination status, and a discussion about how you could benefit from HPV vaccination. What really are the keys to successful messaging? Well, I want you to think, how are pediatricians so successful at vaccinating? There is a reason that they're successful. Currently, we really are taking a participatory approach where we're thinking about the patient or the parent that they might want to opt in to being vaccinated. And so we're asking your wish to participate through consent. We say, do you wish yourself or your child to have HPV vaccination? But the alternative that, if you think about it, your pediatrician often would use is the presumptive announcement approach. So if it's a parent that we're talking to, we assume participation in the program, like an opt-out approach. So for example, Taylor is going into grade 7. We vaccinate all our children against diseases because we care. Next fall, students will be receiving 3 vaccinations for meningitis, HPV, and hepatitis B. HPV vaccination protects us against six types of cancer. Or if it's an adult that we're having this discussion with, then I recommend HPV vaccination to all my patients. HPV vaccination protects against 6 types of cancer as well as genital warts. It's never too late to be vaccinated. We can vaccinate you today. So what did you hear me say? You heard this is a vaccine that prevents against 6 types of cancers. And these cancers affect everyone, including males. We talk about it with all our patients, and that it's never too late. You're not too old, and it's not too late if you've already had infection or disease. What you didn't hear me say, this is a vaccine that protects you against sexually transmitted diseases and infections. And we have to vaccinate you before the onset of sexual activity because we don't have to do that. We've taken the STI discussion completely out of the counseling and talked about cancer prevention. A couple of additional points to consider. Don't assume that a young adult who's sitting in front of you was already vaccinated in our school-based program, because as Vivian showed you, around 50% of kids in Ontario, for example, have not been vaccinated in grade 7 program. And remember that adults that we are counseling about HPV vaccination who understand the importance are also currently or will become parents of children in the future. And the chance that they'll consent their child for vaccination is higher if they believe in it for themselves as well. And as we've mentioned throughout today, the key here is really collaboration with our allied health professionals. So between primary care and specialists, for example, between Vivian and myself as a specialist, but between public health providers at both the national, the provincial, and the regional levels. Pharmacists, for example, in many regions in Canada, including Ontario, have the ability to deliver vaccination doses. Our dental professionals, we're working very hard with dentists and dental hygienists across the country, especially in Ontario, to help them increase their awareness, to help them have the ability to counsel about HPV vaccination in the future. Is that we're hoping that pharmacists and dentists will be able to prescribe HPV vaccines in Ontario. This is already true in other provinces in Canada. Really, our goal for all Canadians, we need to improve awareness, we need to provide the opportunity, and we need to provide the access for vaccination, regardless of your gender, regardless of your age, or your past or current history of HPV infection or disease. We really need to believe in the difference that vaccination can make. Thank you. I'm going to stop sharing there and head back to you, Antonella, there, and to Ian.
Excellent. Thanks. Thank you so much, Dr. Durand. Some more great information. We've got about 11 minutes left this afternoon, so I'm going to kick off right into the Q&A, and I see there's a couple in there. I'm going to start with one of the questions we received from someone who registered a pre-submitted question, and it's for you, Dr. Durand. How do you counsel adults in monogamous relationships about the need for HPV vaccination?
That's a great question. It's a difficult question. We always get scared of how do I jump into that conversation? And here's one of those times where I will use personal examples. Why am I vaccinated? I'm married, I have 2 kids, I'm not expecting any changes in my relationship. The problem is we don't always know what's going to happen in our future. So, as we know, statistics are not on our side. If we have a successful, stable relationship, more than 50% of the time, that's going to break down in the future. Number two, another partner might enter my relationship without my knowledge. So my partner might have another partner, and I want to be protected for that if it should happen. Number three, eventually one of the two of us is going to pass away, and the chance that we'll have a new lifetime partner is extremely high. Just like with adolescents, we don't want to wait for these exposures to happen. We want to protect ourselves before they happen and vaccinate before we're having a new partner, not wait until it's happened.
Great. Thank you so much, Nancy. We'll go to the one of the questions that they're actually related, and I'm not sure if it's Vivian or Nancy who can best respond, but any anticipation of removing the high cost of vaccination adults, and then is HPV vaccine free in Ontario for women outside of the school program? So basically the same question.
So it's not free outside of the school program. A lot of private insurance does cover HPV vaccine. And I think one of the issues is when we talk about the cost of vaccine, we also want to talk about the cost of not being vaccinated. Because when you choose not to be vaccinated, you're choosing not to protect yourself against a cancer. And so I think we have to put it into perspective. Other provinces are covering vaccine for different age groups, so it is province specific. PEI, I believe, covers you if you're high risk and ever having had an abnormal pap test, or more than one partner says you're high risk. But Ontario is not there yet.
Yeah, so I'll just expand a little, Ian, on that. We think of cost as a barrier. That is actually mostly a problem, a barrier for us as the providers. We did a survey about 10 years ago now that we published, and we found in the survey when we asked providers, including family physicians, including specialists, what's the number one barrier to your patients getting vaccinated? More than 90% of them said cost is the number one barrier. If we ask the same question to patients across Canada, only 18% of them said cost was the number one barrier. So what we perceive as the barrier, in fact, for patients is not. And we should not assume the barrier and therefore not talk about it with patients that we think might not be able to afford it.
Excellent points. Thank you so much for that. And I will say there are a number of organizations that are looking at that issue of trying to increase public funding for vaccines that are recommended by NACI but not funded provincially. So there is work going on in that realm as well. So I'll look at a couple of the other questions that came in. Uh, let's see. How about what are the results of the latest studies concerning the efficacy of one dose HPV?
So I'll kick off on that one, and then Vivian, you jump in if you'd like to as well. So the NACI statement that came out last summer was based on 3 studies. Only one of the 3 was a randomized controlled trial. It was 2,000 women only, done in Africa, and they were followed for 3 years. The other 2 were observational studies. There have been no male studies looking at one dose, and this is very important when we talk about oral HPV infection and disease, is does it work in males? Because that disease is predominantly 4 to 5 times higher in males than females. We don't know the long-term duration of protection of alternate dosing, as the randomized controlled trial only lasted for 3 years. There are countries who have adopted alternative dosing, meaning single dose in their school-based program, like Australia and the United Kingdom. These are countries with very high vaccine coverage rates, 80 to 90%. We don't have that in Canada. They have decreasing disease rates for external genital warts, cervical cancer, and precancer. We don't have that in Canada. In fact, cervical cancer has been increasing over the past several years. And as you mentioned, they have robust national registries for surveillance to find out if a flag is put up for alternative dosing. They know who's been vaccinated, they know who's been screening, and they can do recall. We don't have all of those things in place. The largest study, over 20,000 participants, is going to be published probably this year, late this year, or early next year, called Escudo. And this will give us much better information on alternative dosing. So we don't yet have that study to look to.
Yeah. I think Nancy was very complete. And what we know in Ontario this September, Ontario is staying with 2 doses for this year. There may be reasons that were administrative, but Ontario is staying with 2 doses. So hopefully we'll have more information next year before Ontario makes a change. And that would be reassuring because, again, no studies in men and boys and no studies about head and neck cancer. So you're a little bit wary.
So we do have alternative dosing in 2 provinces in Canada, in Quebec and in British Columbia, just announced for this year. So they are moving to 1 dose. All of the other provinces and territories have chosen for this school year to stay with the 2 dose regimen.
Excellent. Thank you both. You answered another question about whether or not the Ontario schedule, 2 dose schedule, was overly cautious or well-founded. So it's a kind of a wait and see. We'll for those studies to come in. That's great. Um, I'm looking, perhaps, so there was a question about what strategies for immunization delivery by public health in a school setting demonstrated increased vaccine uptake. Now, I know Antonella and Dr. Brown, you both touched on those a little bit, but are there any that really stood out that should become a gold standard across the province?
Well, I really liked the public health unit that started the teaching and talking in grade 6, started it before that we were actually immunizing. So parents had the summer to talk about it, think about it. Kids understood they're going back to school in September. They're getting 3 shots. It's meningitis, hepatitis, HPV. Let's lump them together. Let's give that education ahead of time, not at the last minute. And I think uptake showed that it was a benefit.
I would echo what Vivian is saying about that because essentially we need to start the education earlier. We only kind of just learn when it has to happen, and science needs to be much more prioritized within like within the school, especially vaccine science. And actually, Ian, I'm sorry, this segues to a question I have both for Dr. Brown and Dr. Duran, if that's okay.
Of course.
So as a project manager working in science communication and vaccine communication, my question is, as healthcare providers, do you have any recommendations on how to counter the misinformation, especially the misinformation that is targeting reproductive health and the reproductive health of women? And vaccines vaccines regarding reproductive health. Do you have any recommendations that you can maybe give to other providers when
Yeah.
maybe they have patients that are facing or asking those questions to doctors?
Yeah. I think for me, the answer is something that Nancy touched on, which was normalizing the conversation. I ask about medications, I ask about allergies, I ask about immunization. I do that with every patient on every visit because no matter what they're in for, if I'm checking blood pressure, I still need to know what their drugs are, what their allergies are, and what risk they have of various diseases. So when we're talking to women and we're talking about reproductive health, we always go back to the standard of care and we go back to what NACI has said, what the SOGC has said. We go back to where we've got really good guidance. The Federation has created a website on RSV, for example, rsvprotect.ca. Really good information that is important for patients to understand. So when I'm talking to a patient, I usually say, it's not just me saying this, it's me saying this on the basis of the guidelines behind me and where you can find those guidelines or where you can find more information. And Antonella, we often send people to Immunize Canada for some routine understanding of individual vaccines. But in family practice, we're talking about those misconceptions every day. We're talking about Tylenol in pregnancy. We're talking about, some of the newer drugs. We're talking about weight loss, some of the areas where there's lots of trendy information or misinformation online. And we're trying to answer that in a neutral but scientific, knowledgeable way.
Yeah, I think to echo that, when we're having these conversations, the conversation is extremely important, We need to ask, what are your concerns, so that we understand where they're coming from, so we can address what are the specific things that they believe, which may be misinformation right from the get-go. Think as providers, we all need to be more proactive than reactive in getting the correct information out there rather than waiting for negative reports to be written in wherever you get your news, whatever platform you receive your news. We all need to participate more in being proactive in getting those messages out there.
Excellent. And certainly that normalizing the conversation, and when you're talking to the person in front of you, telling them, by the way, I ask everybody these questions. It's not something about you that's made me ask this question, so that it's informed in that way. And the earlier response about the early education, like take a lesson from the recycling movement. They got kids keen on recycling and they forced it on their parents when they went home. So in the same way, you educate the child, you educate the parents at the same time. Well, we are at the bottom of the hour. I just want to thank our speakers so much for a fabulous presentation today. Get back to my notes. I want to thank everybody who joined us and for asking your questions. And we hope the information that's shared will help you engage more confidently in conversations about the HPV vaccine with your patients and the people that you work with. As mentioned before, a recording of the webinar will be available shortly. And before you leave, just please take a moment to fill out the short evaluation that will pop up when you close the Zoom platform. Have a wonderful afternoon. Take care of yourself and be kind to each other.
Thanks so much to
Goodbye.
everybody. Bye now.
Goodbye.